Welcome, everyone. We're going to go ahead and get started. This is the latest in our Institute for Health Policy Studies and Impact program collaboration on how to impact policy. This year, as we have talked about, we are doing a Health Policy 101 as well as current issues series. And this fall, we focused on various forms of insurance. So last month, my colleague in these efforts, Dr. Janet Kaufman, presented on private insurance. Today, I will be presenting on Medicare, both basics, so the 101 for people who are less familiar with the program, as well as some current updates for people who are more familiar with the program. And then we will be back again on November 13th, and Janet Kaufman will be presenting on Medicaid, also a 101 for people who are less familiar with the program, and some updates around current issues in the program. So welcome. Without further ado, I'm going to get started with my slides. Please do remember to put questions into the Q&A. Janet will be monitoring that, and then at the end, we'll have some opportunity to go through those questions. You can certainly add them in at any point, and we'll take them if they're really relevant right in the moment. Otherwise, we'll save most of the questions for the end. I anticipate that we'll have a fair amount of time for questions, so definitely feel free to add them in there. I also want to announce as well that our October 24th deeper dive workshop on how to work with journalists is currently full, but we are building a wait list because oftentimes some people cannot come. So please feel free to email me or Janet or Beth Thu if you're interested in joining the wait list. And just a reminder that this is actually the second time that this workshop has filled up and had a wait list. So if you see in the future a similar announcement for one of our workshops, please do sign up right away so you can make sure to be able to join us. We're thrilled to have so much enthusiasm for this skill building portion. All right, so I'm going to go ahead and share my slides. Get into presenter mode. All right, so today we are going to talk about the Medicare program, both basics and current issues. Here's kind of an outline of what we will cover. So we'll start with a little bit of the history of Medicare. Then we'll get into who's covered, the different parts of Medicare, which sometimes feels a little bit like alphabet soup, but hopefully we'll make that clearer. And then access as well as cost sharing in Medicare. As a result of some of that cost sharing, the different supplemental plans that are available. And then we'll get a little bit deeper into Medicare payments in parts A and B, as well as the move in more recent years toward alternative payment models in Medicare. Then we'll talk about Medicare Advantage, also known as Part C, and some of the basics and the controversies there. Then we'll turn to talking about prescription drug coverage in Part D, and there have certainly been some movement in that area, including some campaign announcements within the last 24 hours. But we'll start with talking about the changes based on the Inflation Reduction Act. And then we'll wrap up by talking about overall Medicare spending and, of course, question and answer. I also want to start by really giving an immense thank you to the Kaiser Family Foundation, who has a new amazing Health Policy 101 resource, and their section on Medicare 101 definitely provided some of the inspiration and content for this talk. And also, as many folks in health policy know, no one does graphics better than KFF, and so many of the graphics that you'll see today are from that resource. They've also just been a fantastic partner to the Institute for Health Policy Studies and host a couple of our medical students as well. All right, so I'm going to begin with a history of Medicare. As many people may know, Medicare passed in 1965 and it was signed by President Johnson. Before this, it's hard to remember, but there were half of seniors who actually lacked medical coverage. And so it was a huge advance. There were certainly people advocating for more universal healthcare provided by the US government. But there was also much opposition and sort of calling of socialism and all these sort of fears. It's important to remember and acknowledge that Medicare was quite fiercely opposed by the AMA, the American Medical Association. And so it was certainly not without controversy. Similarly, 1965 was when Medicaid was passed as well. As I said, Janet will cover that more next month. It actually went into effect amazingly quickly. You know, we've all experienced more recently the rollout of the Affordable Care Act. And so it's quite amazing to me actually that Medicare began and to accept enrollees just 1 year after the law was signed. And then, you know, as we will talk about, seniors were really the first group to be covered, but there have been some expansions over the years. So in 1972, people with disabilities and end-stage renal disease were newly eligible for Medicare. And then some of the supplemental plans came into effect in the 80s. It's also worth noting that a fair amount of the payment system that we currently have, particularly in parts A and B, dates back to the 80s. So we'll go over what these different acronyms mean, but both of those date back to the 1980s. In 1980s, hospice benefits also became available, and sliding scales based on income were developed for the different premiums. Probably the next most significant updates were Medicare Part C, which before was called Medicare Choice, but is now called Medicare Advantage, was developed really in the late 1990s. It was a bipartisan agreement. And then similarly, there was a bipartisan agreement in 2003 to pass Medicare Part D, prescription drug coverage. We'll talk about some of the consequences of the more liberal and more conservative ideas that are in there. And then that took 3 years to really roll out. In 2010, of course, the Affordable Care Act was passed, and it affected Medicare probably a little bit less than private insurance or Medicaid, but it did still have quite significant impacts. So those impacts really include free preventive services in Medicare, reduction in prescription drug cost sharing. There have been more efforts in that regard that we'll cover more recently as well. The establishment of accountable care organizations, and then increased cost sharing for higher income beneficiaries. So if some of this doesn't make sense to you yet, no problem at all. We're gonna cover all of it. But I just wanted to start with sort of an overview, and I know for some of you, these terms are quite familiar. All right, so who has Medicare? In general, there are 66 million people in the US who have Medicare. Including the general groups that are eligible are people who are over age 65, and people who have been on federal disability, so not state or employer-based disability, but federal disability for over 2 years. And then people who have end-stage renal disease or ALS, also known as Lou Gehrig's disease. Why those two diseases? I think it really gets down to advocacy campaigns, particularly with end-stage renal. People set up their dialysis machines in the Capitol, and that was a really powerful advocacy campaign that resulted in people with end-stage renal disease being included. But it's also worth noting that not everyone in these categories has Medicare. So you have to have also been a US citizen or permanent legal resident for 5 years. And you or your spouse have to have paid Medicare taxes for 10 years or more. And so many of the seniors who come to the United States later in life are oftentimes not eligible for Medicare. And that's important to remember. It's actually more challenging to become eligible than for Medicaid in California by far. Looking at what the demographic characteristics are of Medicare beneficiaries, majority women, partly just from women living longer, majority white, and of course, majority people who are over age 65. But there are 13% of Medicare beneficiaries who are under 65. And I think it's worth noting as well that 1/3 of Medicare beneficiaries have 4 or more chronic conditions, and 27% have some functional impairment of an ADL. So ADL, for people who are not familiar, means activities of daily living. So that's things like feeding yourself, bathing yourself. We're not even talking about instrumental activities of daily living or IADLs, things like getting groceries, or doing shopping or organizing your medications or finances. So these are really 27% of Medicare beneficiaries do have quite significant functional impairment. 20% rate themselves as in fair or poor health, and 17% have some degree of cognitive impairment. So now let's turn to talking about the parts of Medicare, and let's start with just the basics of what each of them is. So Part A, quite simply, focuses on inpatient or hospital care. It also includes short-term, less than 90-day stays at skilled nursing facilities or acute rehab. It includes hospice as well as post-acute home health care. But of note, Medicare does not cover long-term care, and it has not covered long-term home health care either. It's really focused on people who have, quote, rehab potential, and does not include longer-term care. Part B focuses on outpatient care, which is also known as clinic visits. It includes preventive services as well, things like colonoscopy, mammography. Part C is also known as Medicare Advantage, and that's actually will end up taking parts A, B, and D all together, combined into one plan. And that is essentially then a plan that's a private insurance plan that's then going to provide all of those services together. They often have covered vision, dental, or hearing aids, partly to attract a probably overall less sick population, and traditional Medicare has not covered those. Part D is focused on prescription drugs, and it is delivered entirely through private plans. Now focusing on how those are actually financed, because it is different across the different parts. So Part A is financed by a payroll tax that people have paid into over the course of their working life. It does not include any premiums, and people are automatically part of it. You don't have to sign up for it. It does include copays and deductibles, which can be quite significant if you're in the hospital. Parts B and D are financed by more general revenues. So things, across the government, all the different taxes that we pay. It's also financed by both premiums and copays and deductibles, although the premiums are sliding scale based on income. I want to take a moment here and just do a little bit of a refresher for anyone who wasn't with us last month, to talk about what are these different terms. So many of us are probably most familiar with a copay. You go to the doctor's office and you pay $20 as just a copayment for the service that you've received. A premium we're also probably fairly familiar with. That's sort of, every month you know that you're going to pay, for example, $300 for your health insurance. I think where people often get tripped up is with a deductible. So deductible basically means that the insurance company is really not going to pay anything until you've paid that deductible. So if you have $1,000 deductible, you're on the hook for $1,000 before the insurance company starts to pay for anything. And so that is where oftentimes people will get tripped up because they'll see a lower premium and find that enticing, not realizing that there's also a higher deductible. And so then they may have signed up and paid for their health insurance, and then they go to actually use it and find that they're on the hook for quite a large bill. So in Part B and D, again, there are premiums, copays, and deductibles. Part C, Medicare Advantage, is financed by general revenues, premiums, and copays and deductibles. It's worth noting that part of the migration to Medicare Advantage has been that actually 70% of people there pay no additional premium. In the law, they can't charge more in premiums than traditional Medicare. But again, this can get tricky because the copays and deductibles can be higher. All right, so access in Medicare, having a Medicare card, what does that actually get you as far as the ability to access care? So one thing just to note, and we'll see that this is different in Medicaid, but in Medicare, the vast majority of beneficiaries do have a usual source of care. Only 4% say that they do not have a usual source of care. And most Medicare beneficiaries actually say that they can get timely appointments. And that actually fits pretty closely with private insurance. There's not a real difference there. This is the latest data out of 2023, so post-pandemic, and looking at all physicians, despite the various threats that you'll hear in health policy, only 1% of physicians are opting out of Medicare. When we look at who those 1% are, 40% are psychiatrists. So we'll see this in Medicaid as well, but definitely psychiatry is probably one of the fields that's most likely to opt out of our public insurance plans. And then we have also seen, primary care within Medicare, and Medicaid also has its challenges as far as reimbursement and oversight. And so we are seeing more, family medicine and internists who tend to do primary care as well as OBGYNs who are opting out of Medicare and are either going to like a concierge model, direct primary care model. But again, these numbers are still low. So when we're looking at that 40%, 20%, 13%, that doesn't mean that 40% of psychiatrists are opting out. It just means that of the 1% of physicians who are opting out, 40% are psychiatrists, 20% are family medicine, et cetera. So overall, I would say access in Medicare still tends to be quite good. When we look at cost sharing, so these numbers I know are a little bit old from 2019, but there haven't been big updates up until now. And we're going to talk in the current issues section about updates with the Inflation Reduction Act. But just to focus in on sort of what is the baseline that we're working off of. There are premiums in both Part B and Part D. And as I mentioned, they are based on income. So there's definitely not the weed, you don't need to get into all the weeds here. But I do think it's worth sort of looking at just the top column and the bottom column, the top row and the bottom row. So if you look at kind of the income at the top, and then seeing what the premiums are. So someone up to $85,000 is paying, roughly $150 in Part B and Part D premiums. Someone who is making, more than $500,000 is, paying, $500-$600 in premiums. One critique from health policy experts has been that this is based on income, not based on assets. And so always when there are talk about how to finance things in healthcare, one of the things that comes up is that these premiums should also take into account assets as well. That's not without controversy, but just worth noting that this is based on income, and you can certainly have seniors who've had quite a bit of income over their lifetimes and have accumulated quite a bit of assets. But then, have a fairly low income in their retirement. Looking at the Part A, it's just worth noting that there's approximately $1,300 deductible. And then there are also, if people are in the hospital or rehab for more than 60 days, then the co-insurance. So co-insurance, just to remind folks, is a percentage. So if we look at the cost, which can be quite a lot, let's say the cost is $10,000 in the hospital. If you have a 5% co-insurance, that means you're going to pay 5% of that $10,000, and that's going to work out to be quite a bit. And so just to say, if you end up with a more prolonged stay in a rehab or in the hospital, that can definitely end up being quite costly. And then looking in more detail at prescription drugs, the coverage is really quite dependent on how much you've spent already. And so basically there had been something that was called the donut hole, which is basically when you're in that gray zone in the middle, people would be on the hook for quite a lot of money. One of the things the ACA did was to try to close that. And so that's what you see there in gray. And that was something that the prescription drug manufacturers have certainly given some funding toward, but also enrollees still pay some, plans still pay some as well. And you'll see that manufacturers tend to pay more for the brand name drugs and plans more for the generic drugs. All right, so all of this cost sharing means that in general, people often in Medicare need some kind of additional supplemental coverage. If not, they might end up on the hook for a fair amount in terms of cost sharing. And I guess I would say positive news is that most people in Medicare actually do have a supplemental plan of one kind or another. So 25% have an employer-sponsored plan. That might be because they're still working, or that might be because they have basically been able to take their employer-sponsored insurance and carry that with them into retirement. 20% have a private supplemental plan called Medigap that they've purchased in addition. and 20% have Medicaid. You'll sometimes hear people who have Medicare and Medicaid referred to as dual eligibles. And so that's a fairly significant proportion as well. And then also Medicare Advantage is oftentimes sort of seen as a little bit more comprehensive of these different services, kind of like, putting things together. And so obviously there's a fair number of people who are in Medicare Advantage as well. Overall, that leaves us with about 3 million people who have traditional Medicare with no other coverage and may end up with significant cost sharing. So turning now to talking a little bit more about how payment happens in parts A and B. And it's worth noting that things are actually quite different between parts A and B. So just as a reminder, part A is hospital care. And dating back to the 1980s, like we had talked about in the history, Medicare has actually paid based on something called diagnosis-related groups, DRGs. And so what that means is if you are in the hospital, let's say for a heart attack, Medicare is going to do some risk adjustment based on the severity of the heart attack you had and then the different chronic medical conditions that you have. But then it's going to pay a fixed amount for that hospitalization. There are some additional fees that relate to procedures, for example, but overall, Medicare is paying a fixed amount for that hospital stay. That leaves us with an incentive for hospitals to, in general, have a shorter length of stay, get people out of the hospital as soon as they can, not do extra testing while people are in the hospital. And that's certainly something that those of us who are clinicians see impacting our practice. There are also some additional payments in Part A, particularly for rural hospitals, for hospitals that care for more low-income patients. So that's called disproportionate share hospitals, or DSH payments, you'll hear said. And then also some payment for residency programs. There's a direct payment for residency programs separately. There are also indirect payments, acknowledging that sometimes the length of stay is going to be longer when residents are involved, for example. In Part B, things are quite different. So just to remind us, Part B is for outpatient or clinic visits. And in that case, dating back to the 1980s, Medicare pays providers based on a fee schedule. And that fee schedule includes two components. The first is the relative value of each service. So by relative, it means basically the value of that service relative to every other service. And so that is all negotiated by something called the RUC, which is a committee that the AMA sponsors that has physicians from every specialty participating in it. One of the critiques of the RUC is that, like the US Senate, every specialty gets a vote, but that may be, for example, a very large specialty like family medicine may get one vote, and then a very subspecialized area of medicine may also get one vote. Overall, it tends to lean more toward higher payment for procedures and specialty care than for more cognitive focused care or primary care. At least that has been the case historically. And as we mentioned, it dates back to the 1980s, and the initial starting point was focused at a time when, in general, I would say procedures tended to take longer than they do now, and cognitive care tended to be simpler than it is now with all the different medications we have to offer, et cetera. And so that is definitely an area of controversy. In recent years, there has been an effort to revalue things and to actually increase payment for the cognitive services and to decrease payment for procedures. That has certainly happened in recent years. But I think many would say that it's still not what it would ideally be based on the data. In addition to those relative values, there's also a conversion factor, which is basically the dollars per value that Medicare is going to pay. And that has decreased some in recent years, even with rising cost of inflation. And I think there's certainly been critique about that from the healthcare industry, but there also from a health policy standpoint, we see that obviously Medicare and US healthcare spending is quite high compared to other countries. There are adjustments made for geography, and that is certainly an area that is very controversial within the Congress, certainly more by geography than by party. So even within a caucus, you'll see quite a bit of controversy around the adjustments made for geography. And then one other area of controversy worth being aware of is, of course, doesn't make a lot of sense that Medicare is paying for volume more than value, and we'll talk about that. So basically, in Part B, the more times you see a patient, the more money you make. The more procedures you do, the more money you make. And there's not really, at least at a baseline, there's not really an incentive to do less or to avoid doing procedures. In addition, one other area of bipartisan interest about changing things is that Medicare actually pays more for the same outpatient service if that's affiliated with a hospital than if it were done by an independent clinic not affiliated with a hospital. And so there is bipartisan interest in making payments what people refer to as site neutral. I think there's been a lot of concern that some of the consolidation that we've seen in the healthcare market, which overall drives up cost, has been partly because of these not site neutral payments, among other factors. All right, so as I mentioned, there have been a lot of interest in health policy circles over the fact that it really doesn't make sense that we in Medicare Part B are incentivizing physicians and others to basically do more, to do more procedures, to see people more often without much in the way of reward for quality and the quality of care that you're delivering. So there has been beginning really in 2015, but also in some ways earlier than that, in 2010 with the Affordable Care Act, there have been moves to like quote paying for value instead of volume. And part of what has happened there is that clinicians actually receive some incentives for participating in what's called alternative payment models. So alternative payment models basically simply is anything other than this fee-for-service model, but also often includes bearing some financial risk for the cost of patient care or for quality benchmarks. One type of alternative payment models that the Affordable Care Act really began was something called accountable care organizations. So that is basically a group of different providers that form a partnership to collaborate and share accountability for quality and cost of care. Patients then either volunteer to be part of it or often are assigned to it based on who their primary care provider is. Interestingly enough, they can still receive care outside of the accountable care organization, for better and for worse. I think there's certainly been a critique from healthcare organizations that participate in them that they can't then be responsible for the cost of care, even though they are held responsible for the cost of care outside of the organization. I think others would argue, well, you should do a better job then of caring for them so that they don't want to go outside of your organization. Overall, again, as part of the ACA, the Center for Medicare and Medicaid Innovation, or CMMI, has designed and tested more than 70 alternative payment models. So far, only 6 have shown consistent enough savings, and 4 have been made permanent in Medicare. This is things like enhanced home care services and also diabetes prevention programs, for example. In 2022, the Medicare Shared Savings Program, which is perhaps one of the earliest and best known accountable care organizations from the ACA, it saved Medicare $1.8 billion relative to what was predicted. But overall, CMMI has cost Medicare $5 billion in its first decade. It has not produced the savings yet that were projected, but I think that over time we are seeing improvements in that, and it is expected to improve as more is learned. Of course, we may expect that initially innovation may cost money and then may save money over time. As far as which things have actually ended up saving money, one of the interesting learnings has been that in accountable care organizations, that organizations that are accepting both upside and downside risk, so meaning basically if they save money, they get a reward, and if they lose money or cost more than they should have, then they lose money. Having both of those risks is something that, of course, organizations are more hesitant to do, but that has been the only model that has actually consistently shown to save Medicare money. All right, turning now to Part C, or Medicare Advantage. Again, that means just that a private insurance company is basically running Part A, B, and D glommed in together in one plan. And it has become increasingly popular. So between 2010 and today, the share of Medicare beneficiaries enrolled in Medicare Advantage has doubled, basically from a quarter to a half. It's also worth noting that that varies widely by state. And so in Alaska, where Medicare Advantage is not very available, only 2% of people have it. But in other states, it's up to 60%. Virtually all Medicare Advantage plans do have an out-of-pocket maximum of some kind. And oftentimes when you look at why more people have been attracted to Medicare Advantage, I think it's been a combination of things. So one is these additional benefits, so things like, hearing aids, glasses, that again, some studies have shown that part of why Medicare Advantage does that is because you're going to attract in general, according to their studies, more a healthier clientele, which is what ultimately earns them money. So there's that. In addition, oftentimes there have been lower or no premiums, like we talked about. There can be higher deductibles on the back end. I think sometimes the simplicity of not having to have a, part A, part B, part D is also attractive to people. You just sign up for one thing. And there have also been many, many ads as well for Medicare Advantage that seniors see. In addition, if they, some of the extra benefits come from the fact that there are rebates. If they make too much money, they have to give some of that back to the beneficiaries. One way in which they do save money is that they can establish in-network and out-of-network providers. And so, for example, Medicare Advantage plan may be able to say, oh, you can only see doctors at UCSF, but you cannot see anyone outside of UCSF. And as many of us probably know from our own choice of an HMO or a PPO, an employer-sponsored insurance, that is going to save money if you're having a narrower network. And so that is certainly one of the ways in which Medicare Advantage has saved money. They are also more likely to include things like prior auth, where they can then deny certain services as well. MedPAC, which is the Medicare Payment Advisory Committee. It's a prestigious group that I think some folks we know have been on as well. And they advise Medicare, of course, as it says in their name, but seen as very nonpartisan, very reputable, very expert. They have estimated that it costs Medicare Advantage 82% of what traditional Medicare would pay to cover the same services. And so why is that? Probably partly because of, denial of some services through prior auth, and also, through these narrower networks, they can negotiate better rates. But they receive 122% of what traditional Medicare would spend. And so you can see they're actually have quite a bit of profit margin there. Why is it that they're getting 122% of what traditional Medicare would spend? I don't think anyone designed it that way intentionally, but the systems have allowed that to happen. And part of that is because of quality bonuses. So $13 billion in quality bonuses. I think there's probably two sides to that. One is, oh, great. Actually, of course, it's great if the quality is improved. I think others would say some of this is, gamesmanship and just being able to actually do a better job than traditional Medicare of actually doing all the documentation required to demonstrate that you're higher quality, whether you actually are or not. A much larger proportion, $83 billion, is from what's called upcoding. So basically upcoding is, doesn't necessarily mean that you're, conducting fraud in any way. It just means essentially that you're doing a really good job of capturing every little adjustment so that your patients look as complex as possible. So I certainly see this as a primary care doctor. I'm, asked somewhat routinely to make sure that I've made sure that every condition that a patient has is documented in their problem list in their electronic health record, because that is then used for the payment adjustment, the risk adjustment, et cetera. And I think this happens to our hospitalists as well. And so, the health system hires people to actually make sure that everything is, captured appropriately. And that doesn't necessarily mean that my patient is actually more complex. It just means I've done a better job of recording that they're more complex. And that's not fraud. That's all true. I'm not being asked to record conditions that don't exist. But certainly the incentives are there more so in Medicare Advantage, and the companies, I think, do a better job of making sure that every risk capture opportunity is coded. So turning now to Medicare Part D prescription drugs. So the law passed in 2003 and took effect in 2006. It requires involvement of a private plan. So this was a Bush era law, a deal that was bipartisan. Democrats were very motivated to include prescription drug coverage. So were Republicans, but also really had a belief that private insurers do things better than the government. And so you will see that Part D is very focused on the involvement of private insurers and also making sure that pharmaceutical companies don't lose money. So Medicare basically pays plans based on an annual competitive bidding process, and then the plans receive a risk-adjusted subsidy per enrollee. Interestingly enough, though, always insurance companies are worried about risk, and in Part D, it is very generous as far as Medicare actually takes on much of that risk. So Medicare actually pays reinsurance payments. So basically that just means that if someone ends up costing way more than we expected, Medicare really ends up on the hook for a lot of that. And that really limits plans' potential losses or gains. So Medicare has paid for basically 80% of catastrophically high drug spending, so past a certain threshold, which accounts for almost half of total Part D spending. So a lot of, what ends up costing a lot of money are people who end up needing very expensive drugs or many drugs. And a lot of that cost has been borne by the federal government. That is one of the problems that is being tackled by the Inflation Reduction Act. And we'll talk about that in more detail, but overall, plans are going to pay more and enrollees are going to pay less. And Medicare itself may actually pay a bit less. So let's talk about this. The Inflation Reduction Act, which was passed under the Biden-Harris administration, basically requires that the federal government negotiate prices for some top-selling drugs. This has certainly been in the news that are covered under Medicare. They just wrapped up the first negotiations, but they won't actually take effect until 2026. If they had been in effect last year, they would have saved $6 billion. And so that's definitely something that you hear on the campaign trail from Vice President Harris. It also requires drug companies to pay rebates if prices rise faster than inflation for the drugs that their beneficiaries use. It eliminates that 5% coinsurance. Like we talked about, coinsurance can be very dangerous for enrollees, because basically if you're at this very high cost level and then you're having to pay 5%, that can be enough to bankrupt people. And so it eliminates that 5% coinsurance for Part D, where people have very high prescription drug costs. It adds a $2,000 per year cap on out-of-pocket spending on prescription drugs total. That's really helpful because people can actually budget and know, like, at most I will pay $2,000 versus having this unknown expense. And then it limits annual increases in Part D premiums for 2024 through 2030. The overall estimate is that 1 million enrollees will be affected, meaning basically that the 1 million enrollees are paying more than $2,000 per year right now. It also limits monthly cost sharing for insulin products. This has been in the news as sort of, it's like, in my mind, it's like the age, stay on your parents' plan until age 26. It's like the very recognizable campaign promise of like insulin is not going to cost more than $35 for people with Medicare. And also it eliminates cost sharing for adult vaccines under Medicare Part D. This I have seen primarily affecting my patients who are trying to get the shingles vaccine, Shingrix, which came out more recently and is much more expensive. And I had a number of patients who were not able to get, who now can get it. So what does this overall look like? And this I know is a little bit busy. Let's focus on 2023 is sort of the before the Inflation Reduction Act, and 2025 is where we're getting to. 2024 is sort of an in-between year. But basically, as we look at things, previously Medicare, as I mentioned, paid like 80% for when someone has really high catastrophic expenses. Now that's going to go down to 20%. Instead, 60% will be paid by the Part D insurance plans and 20% by drug manufacturers. Of course, people pay 100% of their deductible. When we look at that more initial coverage, it's not too different. The enrollees are still going to pay 25%. Now drug manufacturers are going to pick up 10%, and then the plan 65% instead of 75%, as well. And then we're really going to get rid of that coverage gap in the middle. All right. Some particularly clinicians may be interested in knowing what are the prescription drugs that actually Medicare is now going to negotiate the price for. This was determined basically based on things that are, quite popular and also cost a fair amount of money. And so you can see that they result in quite a bit of spending for Medicare and potential savings. If you look at what are the overall categories here, they're essentially some of the newer diabetes and heart failure medications, which has had significant advances in the last few years, as well as some of the newer anticoagulant medications that if people can't afford, they end up having to be on warfarin, which often means they need to go for lab checks like a couple times a week. And it is really a quality of life issue versus being able to be on these medications, which are more expensive, but quite effective in treating blood clots. Down lower, you'll see that some of the medications as well are ones that are used by fewer people, but are quite high cost. So these are often immunosuppressive medications for things like psoriasis, Crohn's disease, rheumatoid arthritis, all autoimmune. All right, so I'm going to wrap up now by talking about Medicare spending, and then we'll head to questions. So just a reminder to please put your questions into the Q&A. Overall, we hear a lot of talk about, Medicare is going bankrupt. And so it's worth thinking about what is actually Medicare spending. It accounts for basically about 20% of national healthcare spending. And if we look at the federal budget, it accounts for about 12% of the federal budget total. If we look at sort of the change over time, the Medicare spending per beneficiary does continue to increase, but it's actually increasing slower than the increase for private insurers. And that rate of increase is decreasing, if that makes sense. So you see on the graph there on the bottom left that the slope has declined over time. There's definitely been debate over to what degree the Affordable Care Act is responsible for that versus sort of broader trends and additional legislation. Overall spending is moving towards Part B, outpatient, and Part C, which is, again, Medicare Advantage bundled together, while spending on Part A, hospital stays, is decreasing. I think some of that is how the program is designed as far as the payment models, but also some of that is just that more and more medical care is able to be done in the outpatient setting. We also hear, like I said, this sort of Medicare is going bankrupt. There's always projections around the Medicare Trust Fund and when it's going to run out. The current projection is 2036, so 12 years from now. And that has varied from basically 5 years out to 19 years out. So it's not perfectly predictable, but overall, we are still in trouble as far as the Medicare Trust Fund, at which point we're going to have to decide how we would fund that Part A. Part B and Part D are not really affected by that because they're funded more by premiums. But as costs go up, of course, the premiums may go up as well. All right, so that was quite a whirlwind of Medicare, both basics and some current updates. Definitely want to take people's questions now, and I'm going to stop sharing my screen. Just initial question of where can you find this and prior recordings? They are on the Institute for Health Policy Studies website, the IHPS website, which is also cross-linked with the Impact website as well now, I believe. And if you're looking on our website for where exactly they're located, let me look into that and just make sure that I got the right.
Beth, I'll work on that.
Yeah. Great.
Okay, so I'll work on that, folks. Other, questions about the material that Dr. Griffiths presented. I'll maybe ask one to get us started.
Yeah.
We're in the midst of a presidential election, and Vice President Harris was on The View
Yeah.
yesterday or the day before with an announcement about Medicare coverage for home care. Also
Mhm.
announced, at least in terms of a proposal for Medicare coverage
Yeah.
of home care and for vision and hearing. And I wonder if you could speak to those, particularly home care, because my
Yeah.
understanding is Medicare does cover some types of home health
Yeah.
services. So if you could clarify that, that would be
Yeah.
fantastic, I
Great.
think, for our audience.
Wonderful. Like, thank you. Such a great question. And if I had just a little more time this morning, I might have added a slide for that, but I am thrilled to talk about that question. Just to clarify, as far as the, hearing, dental, vision, that portion, the proposal is that traditional Medicare would cover that as well, so that that would no longer be a distinction between some Medicare Advantage programs and traditional Medicare, and may also help to sort of, even the playing field. As far as the home health piece, two thoughts on that. One is that currently Medicare does cover home health, but only in that sort of rehab period after someone has been in a hospital or had something happen to them, and you have to basically recertify for different periods. It's never, people can have it more than once, but they can't have it for a continuous prolonged period. The other piece in addition to that is that currently Medicare only covers home health care by licensed health professionals, so things like registered nurses, physical therapists, but it does not cover care to help with activities of daily living or instrumental activities of daily living, so things like bathing, cooking, grocery shopping, etc. And so the proposal is to both allow for, my understanding of it is to both allow for longer term, and then also to allow for home care to be covered by people who are not licensed healthcare professionals.
Great. Thank you very much, Dr. Griffiths. Two questions in the forum. So first question, why are psychiatrists opting out of Medicare at a higher rate than other medical physicians in other
Yeah.
specialties?
It's a great question. And I'm sure that if you ask different people, you would get different answers. But I'll try to include, some of them. And then Dr. Kaufman is fairly expert in this area as well. So feel free to chime in too, Janet. But some thoughts I have. One, I do think that there is more of a sort of market for psychiatrists to be able to just do cash pay. Like there are, people who are willing to just cash pay for a psychiatrist in a way that maybe they aren't for other specialties. We are seeing some of that move in primary care as well. But one thing that makes that possible is, for example, if someone wanted to just, cash pay to see a specialist, that becomes, I mean, sure, maybe you can, but oftentimes that's much more linked to things like procedures, different cross referrals, hospitalization, all of these things that people really can't, for the most part, cash pay for, versus in psychiatry and in psychology, I think oftentimes there is sort of like a little bit of separation. Like you may not be needing lab tests and MRIs and all of these things that oftentimes go along with other specialty care. So I think that that's a piece. I think if you talk to psychiatrists, you will also hear that there are a fair amount of sort of regulatory burden and forms, et cetera. You hear that with Medicaid as well, that that's part of the challenge is how much documentation. And so that may be a piece of it. But I would say probably more the former. Janet, other thoughts?
No, I think those are the two most common reasons. With regard to the documentation, I think the other thing to keep in mind is psychiatrists are among the most likely physicians to be in solo or small group practices,
Mhm.
which just don't have the same infrastructure for
Mhm.
billing that large medical groups have.
Yeah, that's a great point. And again, I think that's partly possible because it's not so linked to like lab services and imaging and hospitalization and all these other things. Yeah.
Exactly. All right. So we have a second question. Uh, do you know or do you think beneficiaries save money being enrolled in Medicare Advantage compared to traditional?
Yeah, I mean, I think that's a really tough question to answer. I mean, in some sense, that's the question that like all of us are asking ourselves when we're trying to pick plan for the coming year. And part of what makes it hard is like you don't really know what your healthcare needs are going to be. And so you could try to predict them. And sometimes you know you have a chronic disease and you're on a particular medication, and then you may be able to predict, but you don't know when you're going to fall or when you're going to end up in the hospital or when you're going to get pneumonia. And so I think that is one of the challenges is it is I think quite hard to actually figure out what your expenses are going to be. And so people will, sometimes predict that they're going to save money and then they end up not saving money, but it actually costs them more or vice versa. Yeah. Anything you want to add, Janet?
I no, I think that's a good point. I mean, I do think, um, for folks who have been, say, I mean, that's right about cost. I think another thing folks want to think about is continuity of care. And I think, for example, if you've been a Kaiser member during your working years, and especially if you already have chronic conditions at the time you retire, then I think it's really worth giving a lot of thought to transitioning to the Kaiser Medicare
Yeah.
Advantage plan because of the ability to have that continuity of care and one of the better electronic health, more comprehensive electronic health records. Um,
Yeah,
so
that's a great point. Yeah, I feel like, yeah, in addition to the cost, it's also like your network and seeing your, the people, the doctors or nurse
mhm.
practitioners or whoever that you're already established with, is another key thing that people are trying to figure out and is sometimes easier said than done to actually
Y-
figure out.
Yeah. Oh, yes, yes.
I feel like I'm struggling right as we speak with trying to figure that out. And the websites are not perfect by a long shot.
Great. Well, thank you. Let's move on to one more question. A different but equally important topic. So, anecdotally, it seems to me that more and more very, very, very expensive medications are being approved. Is there any evidence that the introduction of Part D is incentivizing the development of ultra high price medications?
Oh, I'm not sure that I know the evidence in this place, to be honest. I don't know if you do, Janet.
I don't.
Yeah, I don't think I have a real evidence-based answer. So I just want to be honest about that. As far as my own theorizing about it, certainly I do think that um knowing that there will potentially be a market where there's not going to be at least as much in the way of cost sharing that, for example, you know, if we didn't have insurance, and definitely wouldn't be a good thing. I'm not a proponent of that, but if we didn't have insurance, probably the cost of prescription drugs would be more sensitive to what people could actually pay for it. But when there's deep pockets in the federal government or big insurance companies, sure, it probably does overall, you know, incentivize a higher price, particularly when up until now that Part D has been straight up banned from negotiating prices. And so while private insurers, may be able to do some negotiation, that up until now, Medicare really has not been able to do any negotiation of prices. Now, Medicare still has to approve those Medicaid, but there's also a lot of political pressure on that. We see that right now with some of the newer weight loss medications that Medicare is categorically, not covering, and they'll cover for diabetes or heart conditions, but not for weight loss. And I definitely think that's an area of controversy and political pressure going forward, but also, the cost of these medications would be tremendous for Medicare right now if they were to take it on.
I think I'd just add, I think it will be interesting to see now that Medicare has this authority
Yeah.
to negotiate prices. And if after the election, whomever is president chooses to continue that,
Mhm.
do we see any differences in the drug development pipeline?
Yeah.
I think the other thing I will say with these very, very expensive medications is that they range from drugs where the mm, difference in effectiveness compared to older medications is marginal
Yeah.
at best, or even if they're the only thing on the market, the effect is marginal. But then you have things like I think the Eliquis, Beth, that you pointed out,
Mhm.
which really is an
Yeah.
substantial, certainly improvement in the quality of life of people who need an anticoagulant. over warfarin. Now, should it be as expensive as it is? That we can debate, but I just think what makes this complicated is there are some medications here that really are game changers. Back in the day, the new Hep C drugs
Hmm.
like that really are game changers for people. And where, yes, there's political pressure, but there's also evidence that says, yeah, this newer medication could substantially improve the lives of Medicare beneficiaries and others.
Yeah, absolutely. Definitely agree.
Right. We have time for a few more questions. If anybody has them, please put them in the Q&A forum. Mhm. I want to thank you all for attending. Just gonna go once, twice, three times. Okay. All right. Hey, this might be a good one to understand. Why did they make Medicare so complicated?
Oh, what a good question. I mean, I think the short answer to that is probably politics, that these things have happened incrementally. And uh, part of that is involves, like bipartisan negotiations and, one side gets one thing and one side doesn't. And so I don't think anyone would have designed it this way if they were, designing it from scratch. But I think I think politics is probably the short answer.
Yeah, and I think the slightly longer answer is that remember that this program was established in 1965. And, getting back to our previous question, we didn't, this is before the explosion of sort of biotech drugs and some of these newer medications that are more expensive to produce. So I think maybe at that time, part was there wasn't maybe the need for help paying for prescription drugs in the 60s may not have been as obvious as it was in the aughts. I mean, there are other places like Canada where, for example, the provincial health plans, which cover everybody, historically have not, at least across the board, covered prescription drugs. And those are also health plans that got started
Yeah.
in the 60s. So I think that's at that point in the 60s, you know, inpatient care. Also, got to remember there's a lot of stuff that we do on an outpatient basis and in a less surgeries that we do in a much less invasive way now than they did in the 1960s. And so I think that's another reason why at that point there's probably more focus on inpatient care. People were in the hospital longer and getting procedures that just required a longer. I mean, they're in the hospital for various reasons. One of them being they were getting procedures where they really needed more time in a hospital to recover.
Yeah.
Great question, though. Very good
Yeah.
questions.
Yeah. Yes.
Okay, well, we got about 1 minute more. Let's see. No, I don't see anything else. So just remind everyone that our November topic will be Medicaid. And if you think Medicare is complicated, strap yourself in because
Yeah.
Medicaid
Yeah.
is even more so.
Yeah. And I realized actually we didn't get back to you about where on the IHPS website to find the recordings. So feel
I
free to.
paste in the chat
Oh, you did.
in the
Okay.
Q&A forum. Yeah.
Okay. Got it.
hmm
Great.
hmm
Perfect. Excellent. Wonderful. All right. We've got that there. Thanks so much, Janet.
You're
All
welcome. And I
right.
think
And
we're
we'll
at
see you in
time.
November. All right. Bye.
Okay, bye everybody.